Hi, I'm Tracey Nguyen, and you probably know me through social media. A couple years ago, I made my page public because I was on a mission. My mission was to educate my dental colleagues on their role in treating children with sleep-disordered breathing. What I did in my local area is I developed an interdisciplinary team filled with ENTs, sleep physicians, myofunctional therapists, and every single discipline in dentistry: orthodontists, periodontists, pediatric dentists, the restorative dentists, and the oral surgeon. One of the beauties of working with this team is I actually look at everything now. And I've learned so much with all these doctors in my team. If you send me a case, the first thing I'm gonna say is, what is the diagnosis? And there's so many tools that we have today to help you with the diagnosis. One of my favorite is drug-induced sleep endoscopy. And what that is basically the ENT puts a scope through your nose, down your throat, and you're asleep, and we evaluate the collapse. Now, it is not a regularly covered medical procedure, and not everyone can get it covered, but if you can get this does wonders for your treatment options, because really it's about having precision treatment based on your diagnosis, because we cannot put all of these kids in a box and treat them the same. And the challenge is, because we don't know the collapse, we don't know what we're doing is working. But I'll tell you a little bit about the collapse. So here we go. This is velum collapse. The velum collapse deals with the soft palate. So that is a collapse that's a little bit higher. I actually see this quite a bit in children, and this is where the Mellon-Potty score becomes really important for me. If you have a Mellon-Potty score of a 4, I'm kind of thinking you probably have some kind of a velum collapse. Another collapse, the oral pharyngeal lateral collapse. This collapse is very common and can be managed with oral appliance therapy. Now, there's a couple other collapses. Tongue-based collapse. Now, some are saying that if we bring the mandible forward, we can prevent the tongue collapse. Maybe. This is where hypoglossal nerve stimulation is getting a lot of rave, because that is managing the tongue-based collapse. The fourth collapse, epiglottis collapse. That is really low. We can't manage that. That is all in ENT. The challenge is when we're treating these kids, when things don't work, why don't they work? So that's why I'm always going to ask, why didn't it work, and what is your diagnosis? What do we know about obstruction? Well, we know that it involves a lot of sites, and we know that the number 2 sites is the palate and the tongue. So that velum collapse is very common, and that tongue-based collapse is really common. What makes it even worse with kids is it's very common to have multiple sites of collapse. Are you frustrated yet? Don't be. I'm only telling you this because this is why we cannot put kids in a box and treat kids all the same. We need to recognize that there may be more than one collapse. And this is where you have to grab your team. You need to get an ENT. You need to get a sleep physician. You need to get a myofunctional therapist. And then you need the support of your community and your dental colleagues. I love CBCT imaging, but CBCT imaging is not diagnostic of airway function and breathing. It is one still shot. But what do I love about CBCT imaging? I can see tonsils and adenoids. I can see the oral volume space and the tongue space. So I look at that a lot. So if I see a child and there's a tongue bubble, and that is like a little black space in that oral volume space, I'm thinking, if I can get the tongue to fill this entire space, it's going to be outside the airway. If I have a case where there is no oral volume space, I'm a little bit concerned. Why? Because the tongue does not fit. The last thing is obviously the spine. many things we can learn about the spine. Look at the curvature of the spine. You can tell the age by looking at the spine. So there are a lot of good diagnostic tools we can get from CBCT imaging, but just because you have a small airway doesn't mean you have an airway problem. I've seen many children with large airways still is collapsible. And that's why I want you not to put these kids in a box. So what did I learn? So this is a case. This is a case of an 8-year-old boy that walks into my office. This 8-year-old boy, skinny 8-year-old boy, walks into my office, referred from the Pediatric Sleep Center. He had his tonsils and adenoids taken out at 6, but the symptoms came back. So, according to the American Academy of Pediatrics, what are the guidelines? First line of defense, tonsils and adenoids. Second, CPAP therapy. So the recommendation was CPAP therapy. Mom did not want CPAP therapy. Third recommendation, corticosteroids. Mom did not want the child onto drugs. But what ended up happening was the child was not getting any better. So when he walked into my office, he's an 8-year-old kid that has been diagnosed with obstructive sleep apnea at the age of 6 that did not resolve, and now he's on a CPAP. So the question, how do we get him off the CPAP? So my first question was, what's the diagnosis? Where is the collapse? What can I do? So let's look at the first picture. Like I said, CBCT imaging is not diagnostic of airway function, but what it does tell me is that look at the picture. There is no air bubble where the tongue fits. What that tells me is the tongue does not fit. It is too big for the oral volume space. So as a dentist, when I look at that, I'm going to think tongue doesn't fit, jaws are too small, mid-face is set back. And ENT is going to say it's just a large tongue. So what's the diagnosis? We both have different diagnoses. So what I asked for, I would love for you to do a DISE, drug-induced sleep endoscopy. I want to know where the collapse is. I want to know if what I'm going to do is even going to work. And the answer for this child is really CPAP therapy. So this is what we did. I taught my ENT how to use a George gauge while the child is under. So with the scope, she's going to put the scope down the nose through the airway, and we're going to look at the collapse. Fortunately, his collapse was an oropharyngeal lateral collapse. In adults, we manage that with oral appliance therapy. We bring the lower jaw forward, and we held it there. So that was huge for me, because if this was an adult, I could manage this adult. But it's not an adult. It's a child. Are you going to put an oral appliance on a 9-year-old? So what did I do? She did the DISE, she did the George gauge, she locked it in, I took it in, I mounted the case, and once I mounted the case, I knew where the lower jaw needed to be. Thankfully, the lower jaw just needed to be about 2 to 3 millimeters. But with the lower jaw being 2 to 3 millimeters, where was the maxilla? The maxilla was too far back. How do you know? So that's the answer. You need to know where you're going before you make these recommendations. Because if this was a velum collapse, the soft palate collapse, that has to do with a Mellon-Polity score. I would probably be talking to an ENT about, this is a soft palate issue. Or is it the tongue going up against a soft palate? So these are things you have to work with your team about. You can't do this alone. What did I learn from this case? You have to learn to co-diagnose. The diagnosis here was obstructive sleep apnea with lateral collapse, mid-face retrognathic, nocturnal bruxism, poor tongue tone, and posture. That's a lot of dentistry. I think we can help this child. So what did I do? I put him in a bonded expander, with a reverse pull face mask because I had to bring the maxilla forward because the mandible needed to be 3 millimeters forward. And then we're going to do myofunctional therapy. And when he's old enough, based on the stages, then we're going to do functional appliances. And our next step was to make sure the mandible follows. Again, I cannot stress enough how important it is for us to learn how to co-diagnose. What is the diagnosis? Many of you know this case. This mother has over 300,000 shares. This is her journey to getting treatment for her child. Her child was about to be diagnosed with ADHD. A dentist told this mother, your child's ground down through his baby teeth. I wonder if he has a sleep problem. Nobody's told her that. She goes, I didn't think about that. She goes to the sleep physician. Sure enough, he has obstructive sleep apnea. Next step, tonsils and adenoids. Guess what? He still has obstructive sleep apnea after tonsils and adenoids. What did they do? They went to a preformed appliance, and their goal was to treat his mouth breathing. So, which is not a bad diagnosis because I think we have to address the function. But guess what else? He wasn't getting any better. This is the challenges of treating these children. We have to know when to switch gears. It doesn't mean what we did didn't matter because no one's going to say the child did not need the tonsils and adenoids. We just have to say that wasn't enough. So, tonsils and adenoids came out, evaluated the function. He's in a preformed myofunctional device. He's learning how to nasal breathe, but he's still symptomatic. This is his clinical presentation. If you really look at the arches, it's kind of narrow. It's broad right where the molars are, but it really gets narrow by the canines. He can breathe through his nose. He had the tonsils and adenoids taken out. But remember my last case when we put the kid through DICE and we did the George gauge? That mandible needed to be 3 millimeters forward to prevent a collapse. I think that's what's going on here. The function is good. There's no obstruction and there's no soft tissue obstruction. But the issue is, what else is going on? Is there enough room for his tongue? You can't tell that with this picture. So what do I look at? CBCT imaging. I always look at this. Again, it's just one small piece of the puzzle. So if you look at this, actually, there's an air bubble there. So, but in the other image, it completely covers over. So when I look at this, I'm thinking, there's space. He's not as bad as my first kid, but I think he needs more space. I think we need to be a little bit more proactive with his treatment. So I'm not saying tonsils and adenoids was not a good decision. I'm not saying these preformed myofunctional devices was not a good decision. I'm saying is we need to continue to do more. And so what did we do in this case? I actually treated very similar to my last case because the diagnosis is very similar. Obstructive sleep apnea. He still has obstructive sleep apnea. Nocturnal bruxism. He's still grinding at night. Now, I think that he is mid-face retrognathic. I think that mandible is still set too far back. Unfortunately, I couldn't get a DICE in this case. So I'm going to treat this like it was a lateral collapse. I'm going to bring the lower jaw forward and the upper jaw forward. So my treatment, upper expander, reverse pull face mask, and then a lower expander. Once that is where it needs to be, functional devices to bring him forward. He's only 8. I'm not saying that's going to be it. I'm not saying he's not going to need treatment anymore. But I just want to keep that airway patent because every minute the child does not breathe is a risk of neurocognitive damage. We just did a tonsils and adenoid surgery that puts the child at the risk is death, but we did it. And it's not that it didn't work. It just wasn't enough. And this is what I really want you guys to understand. If it doesn't work, it's okay. It doesn't mean it didn't work. It probably means it's just not enough. So I'm going to end it with, what is your diagnosis? And that's what I'm going to go into in some of these modules, is to go hone in on your diagnosis. You can try something, just like we did with tonsils and adenoids. We tried tonsils and adenoids, and it didn't work. And that's okay. And I'm going to show you other techniques that we can try. Thank you.